simple, straightforward, safe, economical, and there is some good improvement as well. So there is no harm in proceeding that way. But coming to a more academic background, and to some extent some sort of a interdisciplinary discourse, I think we need to be more objective at times. That was the core topic of this plenary discussion as well. How can we make the findings, the positive outcomes that we get for the treatment of diabetic retinopathy objective to some extent? And frankly and honestly, treating diabetic retinopathy is not very easy. Even though we are treating it, even though we are doing some or the other treatment for all those patients with diabetic retinopathy in some of the stages, it is not an easy thing. It is very difficult. So, making some claims, let it be any stage of diabetic retinopathy, I shall very choosy to make before making any claims. See, it is a chronic condition, progressive. The third point is very, very important. It has a prolonged subclinical phase. Before the patient is coming to you, or even she or he understands that I have a problem setting in as a complication of my diabetes, things will be slowly moving forward. Something might have already set in by the time the patient is reporting to a clinic. Then irreversible retinal damage already occurs by the time visual symptoms prompt clinical attention. That is what I told. I am giving you these details to show the broad picture of where do we stand. There are approximately 10 plus crore diabetic people, of which approximately 15% is having diabetic retinopathy, and most of them are in NPDR, non-proliferative diabetic retinopathy, which is mainly, largely asymptomatic. The proliferative diabetic retinopathy 3 to 15% approximately, and diabetic macular edema 6 to 27%. So in numbers, this is a huge population.
You said by yourself.
And this is supposed to be one of the major threat for vision. So definitely there is a space for discussing what we can do effectively in diabetic retinopathy, what are the potential areas, where we can do things independently, where should we work together with the conventional ophthalmology, where should we think about the rules of escalation of intervention to the next level, where we can go for a maintenance, keeping under observation style approach, where should we go for Shodhana Chikitsa, where we can go for Shamana Chikitsa, and what is the role of preventive ophthalmology, and what is the role of Rasayana Chikitsa. So there are many fine points which can be discussed. Now, see, these are the risk factors in diabetes which can lead to retinopathy. All are well known: duration, hyperlipidemia, smoking, pregnancy, CKD, obesity. I am not spending much time on this. These are all well known in the literature. Contemporary understanding is a complication, one of the major cause of visual debility. Yeah, the second point is interesting. Of course, as you all are from the academy and I am not, from outside academy, you will be more updated about these things. I'm pretty sure about it, but just I'm brushing up your memories, that's all. It was believed to be caused by the damage to the blood vessels of the retina, called microvascular. So that was a concept up to recently. The diabetic complications can be broadly divided into two: microvasculopathy and macrovasculopathy. Macrovasculopathy is the one which is affecting the brain and the heart, like this. And microvasculopathy, like this retina or in the kidney or in the nerves, like that. That was the conventional, up to recent time, understanding about this. Now it is recognized as a chronic neurovascular disorder. It's a neurovascular disorder. We will come to the details of that point. See, diabetic retinal neurodegeneration, alongside the vascular leakage, ischemia, and neovascularization, increasing evidence demonstrates that early retinal neurodegeneration involved in the neuronal and glial dysfunction, synaptic impairment, and altered neurovascular coupling. It's a recent understanding. And when we are taking the diabetic retinopathy as the model for gathering information about developing an Ayurvedic intervention methodology, this need not be limited to diabetic retinopathy, but in the development of interventional strategy in many other chronic degenerative conditions. These leads can be considered as one important approach how we can decipher the information available at present with any stream of knowledge. Diabetic retinal neurodegeneration has been demonstrated in patients with diabetes mellitus, even in the absence of clinically detectable diabetic retinopathy. This is very, very important. Earlier, we were thinking that the diabetic retinopathy starts with the changes in the vascular architecture of the retina. But now there is evidence that even before this sort of changes which is affecting the vasculature is there, neuronal changes are happening in the retina. That is very significant. And based on that, personally as a clinician, I am trying new things in the strategy of management. So if I was, or in any other earlier presentations of diabetic retinopathy, I have not included this. Because at that time this was pretty a vague idea. Now it has got more clarity that it is happening. So we should be looking at it from a new perspective. The narrative is changed. This is very, very important. Now, coming more to the general information, diabetic retinopathy has a clinical classification of non-proliferative and proliferative retinopathies. So early conventional understanding starts with the non-proliferative levels. Now in the previous slide we have seen that changes in the neural architecture is happening well in advance, but still that has not come to the proper way of clinical classification. It is a fact that it is happening, but that is still subclinical and it requires more advanced and sophisticated mechanisms for getting it understood. So still it is not in the clinical scenario. Still the classification goes like this, NPDR and PDR. So NPDR has got multiple stages. Then it is supposed to slowly progress to PDR. And this diabetic macular edema can happen at any time. That you need not wait for the PDR to happen before it is advancing to the macular edema stage. From the NPDR, all of a sudden it can directly progress to this macular edema. So fundamentally it is NPDR and PDR. So then with or without macular edema is also coming, which is decisive in the intervention as far as the interventions are considered. Normal retina, I am pretty sure that there will be very little participation from non-Shalakia people, so I don't require all these things. So, but anyway, by convention of any presentation, I am following these things, that's all. The changes are evident. Yeah, this is also another view of the same thing. Early diabetic retinopathy, which is more common called NPDR, new blood vessels are not growing. When it starts growing, it is called as PDR. Walls of the blood vessels in retina weaken. Tiny bulges called microaneurysms protrude from the walls of the smaller vessels, sometimes leaking fluid and blood into the retina. Larger retinal vessels can begin to dilate and form irregular in diameter as well. NPDR can progress from mild to severe, and as more blood vessels become blocked, sometimes retinal blood vessels damage leads to edema in the macula. This is what I told earlier. So this is a broad picture about the early diabetic retinopathy. In our understanding or in our approach, this is a very important stage. I will tell why. What is the clinical significance of Ayurvedic intervention in this particular stage? We will come to that later. Advanced diabetic retinopathy, proliferation starts. Blood vessels start growing. And these new blood vessels are fragile and can lead to the retina and vitreous. Eventually, scar tissue from the growth of new blood vessels can cause retinal detachment. And if these new vessels interfere with the normal flow of the fluid, then it can end up in increased pressure within, causing the glaucoma as well. This is PDR. Yeah, these are the representation of changes which is happening. I will not spend much time on it. Stages of progression of diabetic retinopathy. No diabetic retinopathy, again, is a clinical statement. No diabetic retinopathy, in which there are no abnormalities. This is what it changed now. Even when this is the stage, changes are already setting in. That is the funny part of it. Mild NPDR, in which there are microaneurysms only. Moderate non-proliferative DR, in which there may be microaneurysms, retinal dot and dot hemorrhages, hard X-rays, cotton wool spot, no signs of severe NPDR. Severe NPDR, there may be intraretinal hemorrhages, definite venous bleeding, intraretinal microvascular abnormalities, but no signs of PDR. Then PDR with neovascularization and or vitreous or pre-retinal hemorrhage. Again, these are all the conventional understanding about diabetic retinopathy. Now, see, this is the classification. No disease visible. Mild NPDR, moderate NPDR, severe NPDR, PDR. NPDR, again another photo. PDR, you can see the abnormal blood vessels in the arrowed areas. Macular edema classification, no diabetic macular edema, non-centrally involved diabetic macular edema, centrally involved macular edema, normal vision. These are all things which are all known to everyone. NPDR, PDR, both can develop into macular edema. Please note that in the non-proliferative diabetic retinopathy, the present status, the standard of care is diabetic control and keep the patient under observation. No treatment. The other day I was discussing this with a leading vitreoretinal surgeon. So I think, what will you do at this stage? I asked. We will observe the patient. We will keep the patient under observation. Nothing will be done. So what will be your prescription? Excellent diabetic control. Nothing else.